Good afternoon, everyone. Buonasera. Today is our 15th day of our liver imaging series, and we have a very exciting topic today. It's a very hot topic, and it's presented by a superstar. So today, it's my pleasure to welcome and to introduce Dr. David Fetzer. David Fetzer is an assistant professor of radiology and the medical director of ultrasound in the UT Southwestern Medical School in Dallas, Texas. He's also the residency and abdominal fellowship. He did a residency and abdominal fellowship at University of Pittsburgh. He's a member and the fellow of several societies, including the ACR LI-RADS working group for ultrasound screening and surveillance, for contrast enhanced ultrasound, and for research and development. He is a fellow of SRU, the Society of Ultrasound, and in the Training and Outreach Media Committee. He's also vice chair of elastography community and standard presentation and labeling. He is a member of the Society of Abdominal Radiology, RCC Disease Focus Panel, and he got rising star, but I think he's a superstar already. So, despite of his young age and his early years in the radiology career, he already became a superstar. He became known for his expertise in contrast enhanced ultrasound, and he already is a reference for many of us. His research interests are about ultrasound, the technical development, quantitative ultrasound, ultrasound image quality, particularly in HC screening, and contrast enhanced ultrasound, liver imaging, and abdominal intervention. We can go on, and we will not finish on time. So right now, I think I will let Dr. Fetzer speak about contrast enhanced ultrasound with particular and emphasis in LI-RADS. David?
Well, thank you for that warm introduction, Khaled. It is an honor to be talking to this amazing group, and I say that looking at the list of presenters, I do feel like a bit of an imposter because many of the folks on this lecture series are those that I consider my mentors and my teachers and who I look to for guidance and reference. So it is truly an honor and a pleasure to be speaking amongst such heroes in radiology. I also do wish to say that another reason I feel like I'm an imposter is that here in the United States, contrast enhanced ultrasound is just now catching on, whereas around the world it has become a mainstay in radiology. So I'm sure many on the call, such as those from China, India, Italy, and so forth, may find a lot of what we'll talk about today as trivial. We have some folks here on the call who don't know as much about contrast enhanced ultrasound, and I may be able to enlighten them. And those of you who may know more about contrast enhanced ultrasound, please don't pull the curtain away and reveal that I may not know nearly as much as all of you. So bear with me. I do have a few disclosures. However, probably the most important one is that I will be presenting some material out of the yet to be published full manual for contrast enhanced ultrasound LI-RADS, and this manual has consumed the time of many of my colleagues, probably many more hours than myself, and so I don't wish to take all the credit for much of what you'll be seeing. Much of what you'll be seeing is a conglomerate of many hours from many very talented and dedicated people. For our talk today, we'll briefly go over contrast enhanced ultrasound as a modality for those of you who may be new to it. We'll talk about how contrast enhanced ultrasound LI-RADS fits within the larger LI-RADS system. We'll go into some of the details about the LI-RADS, contrast enhanced ultrasound LI-RADS algorithm itself. I will present some examples and then even talk about contrast enhanced ultrasound outside of HCC diagnosis. Keep in mind that there's a lot online about getting started, technical recommendations and reporting and so forth that we won't be talking about today. So part one of our talk is what is contrast enhanced ultrasound?
Assalamu
Here in the United States, it's had a hard time getting a foothold because of some probably unfounded preconceived notions about its safety and about the need for FDA approval of its contrast agents. So keep in mind that none of these reasons should be reasons to keep you from starting. It is incredibly safe. It's no longer research. It is now on label. So for those of you who may have been hesitant in the past, I encourage you to tackle it now. Keep in mind there are now several FDA-approved contrast-enhanced ultrasound agents here in the United States. The two highlighted here, Lumason, as it's called in the US, or SonoView elsewhere, and Definity are likely the two that are the most widely used for liver imaging, at least in the United States today. Keep in mind that in other parts of the world, Sonozoid is a very popular contrast agent. It's not available for clinical use here in the United States, but it has some very unique properties for liver imaging, predominantly that it is actively phagocytosed by Kupffer cells, and you get relative negative contrast agents kind of akin to EUVIS MRI, but that is currently not a component of contrast-enhanced ultrasound LI-RADS, and we won't be talking about this agent in today's talk. So what are these contrast agents? Well, instead of being small molecules, these are particles, fairly large particles, about the size of red blood cells, about 3 to 5 microns. And they consist of a gas core, usually a fluorinated, insoluble, high molecular weight gas, encased by a phospholipid or protein shell. The diagram here is showing you Lumason or SonoView, filled with sulfahexafluoride gas and encased in biocompatible phospholipids. Now, one unique thing about these this contrast agent is that it's completely intravascular. So unlike iodinated agents and gadolinium-based agents that have an extravascular interstitial phase, microbubbles stay within the vascular space. So it is a pure blood pool agent, and you will not see bubbles where you don't see blood flow and vice versa. The other great thing is that it has a short half-life. So it is cleared by the lungs, and you can re-inject about every 10 minutes, and there's no absolute dose limit. So just yesterday, I encouraged my colleagues to use 3 vials in one setting of Lumason because she had to do a liver contrast ultrasound study to evaluate a liver lesion, another vial for biopsy of that lesion, and then the patient also came in for evaluation of a renal mass, which we did simultaneously. But by the time that they were done, all those bubbles were cleared from the system. The patient went home just fine. Another unique thing about these bubbles is that there is a dynamic relationship between the ultrasound pulse and the bubble itself. So during a pulse wave, these bubbles will contract and rarefact. That oscillation, in combination with the fact that they're filled with gas, makes them a very strong backscatterer. And so this gives us an incredibly high signal to background ratio, to the point where we can see individual bubbles, not just in vitro, such as in this video clip here, where you can see small bubbles, individual bubbles in this micropipette. Again, these are only 3 to 5 microns in size, but you can see it in vivo as well. So this is a renal transplant, but you can see individual bubbles, again, 3 to 5 microns in this background of a nearly washed out transplant. Because of this, we're able to administer very, very small doses of contrast on the order of just 0.2 to 2.4 milliliters, depending on your formulation, as opposed to 10 or 100 times that for MRI and CT agents, respectively. At slightly higher pulse pressures, this oscillation of the bubble, the contraction and rarefaction, becomes non-linear. The degree of rarefaction is out of proportion to the amount that it was compressed. This is called stable cavitation, and this bubble with nonlinear bubble response produces strong harmonics to the primary frequency. And so then we can create or design a contrast-specific imaging mode that takes advantage of the signal differences between the background tissues and the bubbles, and use techniques such as phase modulation, amplitude modulation, or harmonic filtering to basically subtract out the background signal and create almost a image. So this is a diagram of how phase inversion imaging works. Send in two opposite phase, and the opposite phases, obviously, from any backscatters that are responding linearly will negate themselves, whereas signals coming from the harmonics to the primary frequency will be relatively amplified. So you get basically a real-time tissue subtraction mode. So in a B mode image in this carotid artery here, you may just see some low-level echoes, but in the contrast mode, you see marked amplification of the signal from the bubbles from the vascular space relative to the background tissues, and in this case, you can see the non-calcified plaque outlined where you wouldn't have seen it before. Before you give contrast, in this dual imaging mode here, where you get your standard B mode on one side and your contrast mode on the other, and before you give bubbles, most of the image will be black, and that's normal. Really, you're only signal from very high reflectors, such as subcutaneous tissues and tissue interfaces. Once you give bubbles, though, then hypervascular lesions will obviously light up. In this case, this was a small subcapsular FNH in this patient with a history of endometrial cancer. Other things to keep in mind is that when we're imaging, we activate a small a contrast timer that will allow us then to know precisely from how long the image was taken from the time that we injected the contrast. Usually we acquire a continuous 30 to 60 second spinning loop up front, and of course we're running here at 9 Hertz, so this is very rapid imaging for 30 to 60 seconds, so it's very rare to miss the arterial phase in this kind of study, giving us an amazing temporal as well as contrast and noise resolution. All right, so part 2, how does contrast ultrasound fit into the LI-RADS system? So this is a diagram I borrowed from Dr. Marks, who gave a fantastic talk, I believe last week, about the recent past of LI-RADS and where contrast ultrasound came in. And as you can see, it was just a couple of years ago. And I can imagine a lot of people, a lot of advocates for MRI and CT were sitting around going, well, why do we need another modality for diagnosing HCC? I mean, we're the big guns. We do a fantastic job at this already. Why do we need another player? Well, keep in mind that every modality has its drawbacks and its benefits. And I don't think any one tool has all the answers. And I think anyone who is knowledgeable and comfortable with a wide variety of tools can offer an individual patient the right test for the right time, for the right situation. And keep in mind that technologies are always changing. So even though we're, we have these modalities at our disposal now, who knows what's coming down the pipe and we'll be replacing imaging as a diagnostic tool for HCC. So we all need to keep our minds open and go where the data takes us. The contrast ultrasound LI-RADS core and essentials have been published on the ACR along with everything else. So a lot of what I'll be talking about today is available online. Again, the manual should be coming out shortly. I like this diagram. I pulled this out, I think, from the MRI CT manual. And of course, everyone here is comfortable with CT and MRI LI-RADS. We've had a lot of great talks on this topic, as well as with treatment response LI-RADS, which I think we're all now fairly comfortable with. Contrast enhanced ultrasound LI-RADS is what we'll be talking about today, and then Dr. Ayat Kamaya on Wednesday gave us a great talk on ultrasound LI-RADS for screening and surveillance. So this kind of shows how these 4 systems work together. And I would like to discuss today how I see contrast-enhanced ultrasound LI-RADS being used in the broader workflow of workup of patients at risk for HCC. The first one I'll talk about is when a patient comes for a screening or surveillance examination and there's an ultrasound 3 or positive finding, and we could go immediately to contrast-enhanced ultrasound, bypassing a lot of this and getting an immediate diagnostic answer, which I think is great. So these are all examples of an ultrasound 3 positive examination on the screening or surveillance study for at-risk patients. And of course, the management recommendations for these is to go on to a multi-phase contrast-enhanced diagnostic study. In this specific patient who we saw in our clinic, we saw this isoechoic nodule observation in the cranial aspect of the left lobe in a patient with hepatitis B and C. And of course, the recommendation is to go on to a multi-phase contrast-enhanced CT, MRI, or ultrasound. And since we had this patient in our clinic, we sent them down the hall, started an IV, brought them right back into our overflow room, and did a contrast ultrasound study. And as you can see here, that observation showed avid, solid arterial phase hyperenhancement, and then mild, late washout. And as we'll talk about, this is diagnostic for HCC. Patient went on to a staging CT examination, and I actually think that this is the best image I could find of this. I'm not just showing you the coronal because I want to hide it from you, but I actually think it's easier to see on the contrast-enhanced ultrasound relative to the CT. But as the core algorithm shows here, we can get down to a LI-RADS 5, and that carries the exact same management recommendations and outcomes as a LI-RADS 5 in the CT and MRI algorithm. So we could definitively tell this patient they had HCC, definitively tell the hepatologist that they have HCC, and then this would expedite the patient's workup, getting through clinic and getting to definitive treatment. Keep in mind that screening and surveillance ultrasound 3 positive observations can also include thrombus in vein, in this case, an expanded enhancing thrombus on this MRI. But we can do the same thing with contrast-enhanced ultrasound. This is courtesy of one of my friends and colleagues, Dr. Rogers from Einstein. And again, she found this thrombus in this frankly cirrhotic liver, went on to contrast-enhanced ultrasound and found an area of thrombus enhancement and washout adjacent to bland thrombus. So again, since our bubble agent is completely intravascular, we can definitively separate out enhancing tissues from non-enhancing tissues because our bubbles are pure blood pool agents. So this was, I thought, a great case, so thank you, Shuchi. Another ultrasound 3 positive observation is parenchymal distortion here as a geographic area with indistinct heterogeneous parenchyma with this refractive shadowing artifact, again, going on to contrast-enhanced ultrasound, confirmed by MRI in this case to be infiltrative HCC. Another case on ultrasound of parenchymal distortion of the vessels, confirmed to be infiltrative HCC with tumor in vein on this CT. But again, we can do same-day contrast-enhanced ultrasound. Another case from Dr. Rogers, somewhat mass-like area of parenchymal heterogeneity with refractive edge shadowing, went on to contrast-enhanced ultrasound showing a large geographic area of arterial phase hyperenhancement. And again, this turned out to be infiltrative subtype HCC. So in this workflow, you can see where if you have an ultrasound LR3 positive observation at screening or surveillance, you can go immediately to contrast-enhanced ultrasound, independent of a multi-phase CT or MRI. Similarly, if a patient would happen to be scanned by a single-phase or non-contrast CT or non-contrast MRI, and an observation was identified that needed further characterization, again, that patient come to contrast-enhanced ultrasound and not have to come back to CT or MRI for multi-phase study. And the benefit here is that if we turn out to be able to diagnose an LR1 or LR2 observation or even LR5, then the diagnostic pathway is essentially done. And in areas where contrast enhanced ultrasound may be more cost effective, maybe safer, maybe better tolerated by the patient, then this modality can play a very important role in this workflow. The other workflow I'd like to talk about that had been mentioned earlier this week is when a patient comes to CT or MRI for a diagnostic study, and that diagnostic study for some reason may not provide all the answers. Either it was degraded by motion or artifacts, the contrast timing was poor, or an observation wasn't completely characterized. Again, I think a modality that can be considered is contrast-enhanced ultrasound. So in this algorithm, after a multi-phase CT or MRI, depending on what the observed observation is categorized as, there are a host of various applications for contrast-enhanced ultrasound. So for instance, on the left side here, if the exam was negative, so we saw something, say, on a screening and surveillance ultrasound, that patient went on to multi-phase CT or MRI and nothing was seen. Well, if that observation was still seen on ultrasound, why not send that patient back to ultrasound to see if we can then characterize it with contrast-enhanced ultrasound? So that's one pathway we talk about its use. Similarly, an LR non-characterizable, so the study was non-diagnostic for whatever reason. Also, if you have an LR3 or LR4 observation, sometimes the contrast-enhanced study can be, ultrasound study can be an arbiter in moving an LR3 observation to LR2 or 4, moving an LR4 observation to 3 or 5 or even M. Similarly, taking an LRM and seeing if we can move it to an LR5. And then for LR5s and M, using contrast-enhanced ultrasound in downstream diagnostic and therapeutic pathways, biopsy guidance, ablative therapy, and so forth. And we'll touch briefly on this in the very end of my discussion. So to round out my advocacy for contrast-enhanced ultrasound, here are some of the benefits. So you are able to leverage some of the inherent advantages of ultrasound. You're portable. So we've gone and done exams in ER and ICU and OR. You know, there's been talk of using contrast-enhanced ultrasound in the front line, obviously not to diagnose HCC, but of course in trauma situations, for instance. Obviously, it's a safe modality, right? This is where one of the biggest benefits of ultrasound. It's very approachable. There's no screening involved. There's no radiation involved. And then the advantages of contrast ultrasound agents themselves. We talked about this briefly. The short half-life, cleared by the lungs, not by the kidneys. There's no renal toxicity to worry about. And I know that the worries with renal toxicity and renal clearance with our current gadolinium-based and iodinated agents is less than it once was, but we still have providers and patients who are wary about these other agents. So we have another option for them. And there's an incredibly low allergic reaction rate. There's no cross-reactivity for their contrast agents, and the reaction rate is likely equivalent to or less than that of gadolinium agents today. I would be remiss if I didn't talk about some of the potential drawbacks of contrast-enhanced ultrasound. Really, this modality only allows for characterization of a limited number of observations per examination, so 1, 2, 3 observations at a time. So it's not good for disease staging. So if you have a patient with AFP beyond imagination, and you have several observations identified at a screening ultrasound study, then obviously a staging study is probably going to be needed, and that patient should go on to CT or MRI. Contrast-enhanced ultrasound LI-RADS is also not currently recommended for characterizing lesions not seen on a baseline grayscale study, and is not currently recommended for treatment response assessment. However, these two areas are areas of active research, and many of you have probably seen a lot in the literature on using this modality to assess response to therapy. And so I think in the next iteration of our LI-RADS, contrast ultrasound LI-RADS update, we'll have mention of these two issues. So in summary, it's an indication for contrast-enhanced ultrasound. Consider it for assessing any nodule seen at surveillance ultrasound greater than 1 centimeter. Considering it to further characterize LRMC 3, 4s, and M observations detected on prior CT or MRI to help further characterize them or to guide in biopsy and other interventions. Using contrast-enhanced ultrasound to follow observations over time to assess temporal changes. So again, in a patient who has tenuous renal function or breathing difficulties or metal in their body, you can use contrast-enhanced ultrasound to follow an observation as opposed to another modality. We'll touch briefly on its use in differentiating tumor in vein from bland thrombus, and as I said earlier, using it for biopsy guidance and other interventions. All right, so let's talk about some of the details of the LI-RADS algorithm. As with many of our discussions the last several weeks, you always start with who, in what population do you apply this system? So very similar to CT and MRI, LI-RADS, we apply contrast-enhanced ultrasound LI-RADS in cirrhotics from any cause, subsets of patients with chronic hepatitis B, or history of HCC. You, again, in the current algorithm, apply it to observations seen on the pre-contrast ultrasound study. We should note that we should not be applying this system in patients less than 18 years, cirrhotics from disorders such as congenital hepatic fibrosis, vascular disorders, hereditary disorders, as discussed in other talks earlier in this series. And obviously, if we already have biopsy proof of what the malignancy is, we don't need to confuse the situation and try to recharacterize it ourselves. This is a widely publicized schematic of a typical examination performed for HCC or a liver observation characterization. And you'll see it's broken up by when we're imaging, when we're looking, and when we're recording, taking images, relative to the phase of enhancement and the relative time following injection. And you'll notice here that the start of the arterial phase is much, much sooner than we expected on a CT MRI. And a lot of it has to do with signal to noise and bubble contrast dynamics. But you'll see here that usually from 30 to 60 seconds, we're watching continuously and obtaining at least a 30-second loop during the expected arterial phase to be sure to acquire all that arterial phase enhancement information, as opposed to just taking one or maybe two or three snapshots during this phase, which can be quite dynamic, as we've seen in other examples on CT or MRI. And then after that, we come back at intervals and look and take images to look for washout, much like multi-phase CT or MRI. So just to talk briefly on these phases of enhancement, they're very similar, obviously, to CT and MRI. The timing is a little different. This is what a typical image will look like before the contrast arrives. But just within 1 second, you see early enhancement of the arteries. The next second, more of the arteries are filling, and of course, more of the parenchyma starts to enhance by about 18 seconds when the portal veins start to enhance to your late arterial or your portal inflow phase equivalent. Then we have the portal venous phase, lasting from about 30 to 45 seconds to 2 minutes. And this is when the parenchyma is almost homogeneously enhanced. Many of the blood vessels are going to be hyper-enhancing relative to the parenchyma. And then we have a late phase, equivalent to the delayed phase on CT MRI, usually lasts from the end of portal venous phase until all the bubbles are cleared from the liver. And you actually may have a situation where the blood pool washes out faster than the liver. The bubbles, since they're buoyant and they're a little sticky, actually transiently stick in the hepatic sinusoid. So they will stick around within the hepatic sinusoid faster than the larger blood pool clears out. So you do get, depending on how long those bubbles stick in the sinusoid, about 6 to 8 minutes of scan time in many patients, far after the kidneys and the blood pool wash out. So that's kind of a fun phenomenon. And then once the blood pool and the liver wash out here at 6 minutes, in this particular patient, we had just a couple of bubbles running around, but essentially this is time when you can consider re-injecting if you need to. A few differences to discuss between contrast-enhanced ultrasound and CT/MRI LI-RADS systems. We've touched on this a little bit already. First, that the ultrasound agent we're using is a complete blood pool agent. So we don't have an extravascular interstitial phase. So for instance, in a cholangiocarcinoma, an ICC that may have delayed central enhancement on a gadolinium or iodinated-based study, you will not see that with contrast-enhanced ultrasound. You will see a diametrically opposed enhancement pattern where you'll get rapid washout. That should not dissuade you if you're seeing those kinds of differences between the modalities. We have an incredibly high signal-to-noise ratio, so it's easier to detect presence or absence of blood flow relative to CT or MRI. We're not having to rely on contraction images or attenuation measurements, for instance. And as we kind of alluded to, contrast-enhanced ultrasound allows for continuous imaging. So timing the arterial phase is less critical because we're watching continuously and can capture a long cine loop of the entire arterial phase, which is nice. A few other differences to discuss is that contrast-enhanced ultrasound LI-RADS is nodule-based because, again, we are targeting in the current version, a observation that is identifiable on the pre-contrast grayscale B-mode image. So a lot of the LI-RADS literature for contrast-enhanced ultrasound will say nodule as opposed to observation. We have fewer major features, so we do not have a capsule-like enhancement at contrast-enhanced ultrasound. Similarly, there are fewer ancillary features, and we'll go through some of those in a minute. And we're not confounded by vascular anomalies, and I think this is an untapped benefit of contrast-enhanced ultrasound, where we frequently call these small peripheral foci of arterial phase hyperenhancement at CT/MRI as LR3 observations, and many of them turn out to be small vascular anomalies, AP shunts, and whatever we call them, and they're just not visible on contrast-enhanced ultrasound. For one, there's no B-mode correlate, and two, we just don't see on the contrast ultrasound side of things any correlate. So this can be a great arbiter if there's a concern on CT or MRI of an LR3 observation that may just be a small vascular anomaly. Finally, and probably one of the most important things to discuss is that both the onset and the degree of washout are critical, not just its presence. So for CT MRI, we talk about unequivocal washout, and then we're kind of done. We really don't care at what point it washes out, whereas with contrast-enhanced ultrasound, that is very important. So this just reiterates the major features for contrast-enhanced ultrasound LI-RADS: non-REM arterial phase hyperenhancement, similar to CT and MRI, and washout. But again, we define that as either early or late, and we have a cutoff of 60 seconds. So less than 60 seconds is early, 60 seconds or later is considered late. And we characterize that washout as either marked or mild. And again, that also has a time cutoff to it. We'll come back to that in a minute. So the arterial phase hyperenhancement, again, we want to see non-REM AFI. If we see REM AFI, again, we're considering an LRM observation. We also look for hemangioma-like AFI. So this is obviously the peripheral discontinuous globular enhancement, and we can immediately characterize that as an LR1 observation. Here are some cases. This one happens to be from our yet to be published manual, showing both on this CT a hypoenhancing rounded observation in the left lateral segment, delineated by the yellow arrows. And then just peripheral to that, delineated by the blue arrow, is a wedge-shaped area of arterial hyperenhancement without corresponding washout. And of course, all of us who are pretty familiar with CT and MRI LI-RADS and reading these studies, this looks like a small vascular anomaly or AP shunt. On the corresponding contrast-enhanced ultrasound, we see the observation in the left lateral segment, and we're able to see the contrast-enhanced, the arterial phase hyperenhancement that was not seen on the arterial phase of that CT. And then we start to see the slow, mild, late washout definitive for HCC, a LR5 observation. Note that we do not see the AP shunt as seen on that CT. Here is a, we should say rim assay, I apologize. Here's a observation seen on MRI with a rim arterial phase hyperenhancement and delayed central fill-in. And here on the corresponding contrast-enhanced ultrasound, you see a continuous, so irregular rim of arterial phase hyperenhancement and rapid marked washout in this patient that turned out to have a peripheral intrahepatic cholangiocarcinoma. The hemangioma-like arterial phase hyperenhancement, we're all familiar with this, and it looks very similar on contrast ultrasound as compared to CT and MRI. This peripheral discontinuous globular enhancement or puddling with slow intrapital fill-in. Shouldn't be a diagnostic dilemma in most cases. However, do keep in mind that many hemangiomas will not completely fill in on contrast-enhanced ultrasound. Again, I think more hemangiomas have a central scar or thrombus than we appreciate on CT MRI because of that delayed interstitial extravascular phase, whereas on contrast-enhanced ultrasound, it might be a confounding factor. So in our practice, if you see this enhancement pattern, even if we don't see complete fill-in, we are still pretty confident of calling that hemangioma. Washout, again, I want to come back to this because it's very important. Onset and degree are both important. Onset being either less than or greater than 60 seconds, being early or late, respectively. And degree, we talk about mild or marked. So marked is considered almost devoid of enhancement, almost appearing punched out in appearance within 2 minutes after injection. We do know that some HCCs will have this appearance later, say 3 or 4 minutes, but that shouldn't dissuade you. We consider the complete punched out appearance as marked washout if it occurs less than 2 minutes. Mild is, of course, any degree of enhancement that is not marked at any time point after injection. So this just puts that same information in a diagram form, but I think what's more helpful is to consider an adjunct to the normal chart that we're used to seeing with the no AFI and not rim AFI columns based on size, keeping in mind that we're always looking for either early or marked washout, which automatically push that observation to LRM. The reason that this is so important is that when we first started to advertise contrast-enhanced ultrasound modality as a modality for diagnosing HCC, many cholangiocarcinomas were misdiagnosed as HCC, and obviously that created a lot of concern and a lot of headaches in managing those patients that were misdiagnosed. And so the AASLD in their guidelines removed contrast-enhanced ultrasound temporarily from their management guidelines, and that put probably 5 or 10 year delay in the acceptance of this modality in the workup for HCC in the United States. But with this very strict criteria of using early and marked washout definitions, we've been able to correct those diagnostic dilemmas, and that is supported by some literature I'll show here in a minute. This is that same case I showed you earlier, just showing that this washout was identified within 46 seconds and became marked or almost devoid of contrast or punched out in less than 2 minutes. So this is early and marked washout in this patient with intrahepatic cholangiocarcinoma. I said there were fewer ancillary features, and this is it. Definitive growth, nodule and nodule architecture, and mosaic architecture. Again, very similar to CT and MRI LI-RADS. And ancillary features favoring benignity with the stability for over 2 years and size reduction. Keep in mind that for size reduction and size increase, we do not yet have strict cutoffs for that, and that's something that we are looking into and trying to add into maybe future versions of the contact lens ultrasound LI-RADS manual. To reiterate, an LRM observation is one in which we're either seeing REM ASCII, early washout, or marked washout, as discussed earlier. We can also use this modality to differentiate malignant from bland thrombus, which I think is another untapped use, often because enhancement of thrombus can be a diagnostic dilemma on other modalities. So obviously we're looking for enhancement of that thrombus, usually around the time of the hepatic artery opacification. We don't expect to see bubbles in the portal vein at the time we're seeing enhancement of the artery. Again, we're watching in real time, so it's easy to save that clip, go back on PACS, and watch the inflow frame by frame and confirm that those bubbles are arriving in that thrombus at the time that the arteries were opacifying, indicating arterialized thrombus, as opposed to bland thrombus, which obviously shouldn't be devoid of any, or should be devoid of all contrast unless you have pre-canalization. But then that enhancement should come much later than the hepatic artery at the time of the expected portal inflow. In the published documentation, we have these cards and with helpful information about each of the LI-RADS categories. Non-characterizable, obviously very similar to CT and MRI, in which the study is so degraded by artifact or other issues that we're not able to characterize an observation in any form or fashion. LR1 observations, we have some examples, but not to be an exhaustive list, but things that we commonly encounter are simple cysts, hemangiomas, focal fat deposition or sparing, or hypertrophic pseudomass. These are considered LR1 observations, and of course we have what to do, management guidelines for what to do if you're unsure between LR1 or LR2, and so forth. LR2 observations would be those that we are fairly confident are benign, but don't meet criteria for LR3. You don't have to go through the details. There aren't any real specific pathologies in this category, but more, we think it's a hemangioma, but it has atypical features, or it's a small observation without any hyperenhancement or washout. These are the few observations that generally make it into this category. Keep in mind that FNH and adenoma are not commonly encountered in cirrhotics, and so these we suggest should be categorized currently as an LR3 observation, just so that they don't get lost to follow-up, and we continue to follow them to ensure that they are indeed suspected FNHs or adenomas. Adenomas have just like in CT/MRI, have a lot of overlapping features with HCC, and so we rarely are able to definitively characterize them as contrast lens ultrasound, but again, we won't have to go into details of that today. LR3 observations and immediate probability for malignancy, those would be observations less than 10 millimeters that have arterial hyperenhancement without washout, or those that have some degree of enhancement, but it's not hyperenhancement. And we can go through some of those examples here in a minute. LR4, again, probably HCC, but not 100%. And definitively HCC, similar to CT and MRI. Again, we have some criteria for tumor in vein and management guidelines, and LRM and its management guidelines. But instead of reading these to you, I'd like to instead go through some case examples. So this was one of the first cases that we actually did at UC Southwestern. I was actually asked to biopsy this patient. It was a patient who had an indeterminate nodule seen on CT and MRI with a history of hepatitis C. On our B-mode image, obviously, we have a hyperechoic nodule in the inferior right lobe with internal blood flow. Here's the arterial phase images, just snapshots at 23 seconds, 26 seconds, and 37 seconds. And you can see solid arterial phase hyperenhancement, and it did show mild, delayed washout. And so I called up the hepatologist, and I said, hey, this is an LR5 observation, we're done. But that hepatologist happened to be one of the authors of the AASLD guidelines, who at the time was waiting for the evidence to add it back in, and so we still proceeded with the biopsy, which turned out to be low to intermediate grade HCC. So since this case, I think the comfort level at our campus has gotten a little better. And so some of these cases either come from my institution or from our LI-RADS manual. Here's your classic HCC, your definitive HCC LR5 observation. Something identified on the B-mode image is greater than 10 millimeters, showing arterial phase hyperenhancement and mild late washout. Going to the diagnostic table, you get to LR5 definitive for HCC. Here's a similar observation at 3.4 centimeters, showing arterial phase hyperenhancement and mild washout at 1 minute 21 seconds. It does become marked, but this marked washout is after 2 minutes. So we can still utilize the mild washout between 1 and 2 minutes as a diagnostic feature and definitively characterize this observation as HCC. Here's an observation on B-mode image that showed arterial phase hyperenhancement, but early and marked washout. At 30 seconds, it's already washed out. So we shouldn't even go down to the diagnostic table. Instead, with the marked washout, this is an LRM observation. Similarly, this patient showed early washout at 34 seconds, marked washout at 4 minutes. But again, the early washout means we don't go to the diagnostic table, we characterize it as LRM. Briefly, here are some LR4 probable HCC observations. So a couple of hyperechoic nodules in the anterior part of the liver, measuring 10 and 20 millimeters respectively, showing arterial phase hyperenhancement, but persistent enhancement relative to the adjacent liver, no washout. And as you can see with the diagnostic table, that qualifies as an LR4 observation. Here's a small observation. Forgive me, I don't have a B-mode image, but it was small, 9 millimeters, and it should be an LR. Oh, no, I'm sorry, this was 12 millimeters, and another observation qualifying as LR4. This one, again, over 10 millimeters, showed ice enhancement and washout at 3 minutes, LR4. This one was 9 millimeters, showing arterial phase hyperenhancement without washout, LR3 observation. Here's a 2.5 centimeter observation without arterial phase hyperenhancement and without washout. So looking at the diagnostic table, we're in the column of no AFI, greater than equal than 2 centimeters, LR3. And then less than, obviously same thing, without arterial phase hyperenhancement or washout, we're still in the LR3 category, in this case here. And similarly with this case here, we do have some washout, but without the arterial phase hyperenhancement, this still qualifies as an LR3 observation. So going through the features and assigning the category is very similar to CT and MRI, LI-RADS. So what's the literature say about this? We came out with this system, now 4 years ago, and just like with CT and MRI LI-RADS, it took several years to collect outcomes data, and then even based on those outcomes data, produce several iterations of that algorithm to refine the algorithm and change the management outcomes to fit the intended probability of HCC in each of these categories. So similarly, we came up with this for contrast enhanced ultrasound, where the intended probability for HCC in the LR5 should be 100%, should still remain very high for LR4, maybe about 50% of the time for LR3 and so forth, and very low for 2 and 1. And LRN is still going to have some HCCs as expected, as intended, but this is where we'll catch all the non-HCC malignancies as well. So there have been several publications, and I want to draw your attention to the last column here. This is the current U.S., multi-country, multi-state, multi-institution trial led by Dr. Lishik at Jefferson in Pennsylvania. And this is yet to be published interim analysis data. You guys, I have permission to show this from Andre, but he said that this is yet to be published data that was preliminary presented at the last SAR meeting. And the LR5 category, as you can see across all these studies, about 97 to 98%, and this is equivalent to CT or MRI, actually equivalent to MRI and better than CT. LRM, there's some variability, but again, about half of LRM observations turn out to be HCCs, and the non-HCC malignancies are caught in this category. LR4 observations in our series, 89% are HCC, and across several studies, about 50% of LR3 observations are HCC. So we're still waiting for enough data to fill in the LR2 and LR1 rows here, but keep in mind that we'll have a 2-year follow-up or biopsy or definitive multi-phase study follow-up for all of these observations, and with final results expected in about 1.5 to 2 years. All right, my last couple of minutes, I just want to highlight some uses of contrast enhanced ultrasound beyond HCC. So obviously, a simple cyst is a simple cyst is a simple cyst. So what's nice is that degree or infiltrated material will not enhance. Thin septation may show a little bit of enhancement, but shouldn't dissuade you from definitively characterizing this as a simple cyst. Hemangioma with a hemangioma-like enhancement patterns. It's peripheral discontinuous globular enhancement, centripetal fill-in. The lesion should follow a blood pool. Focal nodular hyperplasia, this is really fun. Just like on catheter angiography, will enhance from the central stellate scar and have this spoke wheel enhancement, and the observation will become iso-enhancing the liver without washout. And that enhancement pattern is quite specific for FNH. This is just some images from the literature to show you guys that I'm not lying. This is fairly well published for contrast enhanced ultrasound. We use this modality a lot for metastasis, not just for identification and characterization, but also for biopsy guidance, because almost universally liver metastases will wash out, not just mildly, but early and markedly. And so within just a few seconds, most metastases turn into these big black holes, which makes them easy to count, characterize, and target for biopsy. This is a recent case of mine. This patient had a, quote, liver cyst that had increased in size and complex features. She was 89 years old, and they didn't want to send her to CT MRI, so I offered contrast enhanced ultrasound. And here you can see an enhancing mural nodule in this otherwise anechoic structure. So we diagnosed this as a mucinous neoplasm of the liver. We've been using it for gallbladder pathology, so not just like these cute little polyps, but also to differentiate gallbladder carcinoma from biliary sludge or tumefactive sludge. And we've prevented surgeries in some patients and diagnosed otherwise missed carcinomas in other patients. So I think given the temporal, spatial, and signal-to-noise benefits of ultrasound, I think gallbladder imaging is underutilized by this modality. Other uses that I won't only touch on, but are very actively and widely published in the literature, are the use of contrast ultrasound in response to therapy. It could be targeted therapy or chemotherapy. And something I won't talk about today, but is also really interesting as a marker for aggressivity of the lesion as well as response to therapy, is analysis of tissue perfusion. Again, because we're watching in real time using a pure blood pool agent, perfusion analysis is actually much easier to do on contrast ultrasound than other modalities. This is another 89-year-old lady who had a prior ablation of an HCC. That's what the echogenic shadowing focus is here in the inferior right lobe. One of our astute sonographers identified a subtle hypoechoic nodule adjacent to the zone of ablation. We offered contrast ultrasound showing this avidly enhancing nodule. Even though this patient couldn't hold her breath, free breathing, we're still able to keep that nodule in view and show that it has arterial phase hyperenhancement and washout. This is a sped up clip, by the way, so it's not washing out that fast. And so then we use contrast ultrasound to target for microwave ablation, as this cloud of gas is, and nearly immediately after we ablated it, the interventionalist wanted to make sure that the adjacent gallbladder wall maintained perfusion. So on the still image here, we see plenty of enhancement of the adjacent gallbladder mucosa. Where that observation was completely devoid of enhancement, and all we're getting is some artifactual signals from some of the macro bubbles in the center of that ablation bed. And it's just really cool to watch this in real time as that parenchyma enhances, showing that huge zone of ablation where that prior HCC used to reside. We've done a little bit on monitoring observations after TACE. So here's an observation with areas of complete necrosis, but some areas showing residual viable disease. Obviously, there's no treatment response algorithm yet for contrast ultrasound, but we're hoping to develop that soon. This is confirmed by follow-up MRI. So in conclusion, I consider contrast ultrasound a very unique modality that should be in the tool belt of every radiologist who does serious liver imaging. There are unique properties of the contrast agent we use. It's rapidly cleared from the body. There's no interstitial phase. You can use those differences to troubleshoot for certain patients and for certain observations. Since there's this dynamic ultrasound bubble interaction, we can play games. We can clear bubbles from the blood pool faster. We can do these real-time tissue subtraction images. We can do perfusion analysis, which is unique to this modality. Obviously, we're watching continuously. We can give multiple injections, the high signal-to-noise ratio, so there's a lot of great benefits to this modality. So we use it, and I encourage you all to use it as an FDA-approved agent for liver lesion characterization in your HCC and your non-HCC population. It has shown to have a high accuracy for differentiating benign from malignant lesions in the liver and in the kidney. It is obviously a very safe modality. It can be used for same-day characterization of lesions identified on a scanning or surveillance ultrasound. And obviously, it can be a troubleshooting tool when your CT or MRI are either confounded or you want to move an observation, an LR3, LR4, or LRM observation into another bucket. You can give it another chance utilizing this modality. Again, I wish to thank the entire crew of the contrast ultrasound LI-RADS working group. I came in about 2/3 of the way to development of this algorithm, and so I cannot claim a lot of credit for all the material you just saw. And I, again, feel like a little bit of an imposter representing this fantastic group of colleagues, friends, and mentors in this session. But I hope I was able to provide you with some good information, some good ideas, and good insight into this fantastic modality. Thank you.
Thank you very, very much, David. That was a very great lecture. It was very informative. We really appreciate that. It was really informative, and I actually feel how eager you are to just deliver and give everything you have to the audience. So thank you very much for that.